Hello, everyone. Welcome to this workshop on artificial intelligence in surgical practice. I am Dr. Karthik, consultant head of head and neck oncology at Sri Shankara Cancer Hospital, Bangalore, India. Um, Special thanks to Dr. Deepak Haldik, Dr. Vishwas from Trustwell Hospitals, Bangalore, along with my immense gratitude to the Microlabs team for organizing this EN Train workshop, which is held online as well as offline, and giving me an opportunity to give this small short course on artificial intelligence and how to use artificial neural network in clinical practice. So in next 35 to 45 minutes, we'll be discussing about the insights and the role of artificial intelligence in clinical practice. So a short survey was done recently by the American College of Surgeons. They asked about the surgeons' attitude towards artificial intelligence. So majority of the surgeons said that artificial intelligence is the future and it is for the betterment of surgical team. There are only a very small subset of surgeons, less than 5%, feared that the artificial intelligence may replace their job as surgeons. A very, very small subset of surgeons felt that artificial intelligence does not help in surgical practice. Surgery is a very complex process. It is high stake, team based, technology, and extremely data intensive place where almost around 65% of medical error tends to happen. And artificial intelligence can be used in this place to minimize medical errors. We need to understand the various stages of artificial intelligence. On a broader scale, artificial intelligence is divided into three stages. Machine learning is the stage one, where the artificial intelligence is able to perform a simple and straightforward task. The stage two, also known as artificial general intelligence, or also known as machine intelligence, is similar to humans, where it is able to perform complex tasks with active learning. The third stage is also known as artificial superintelligence, stage three, or machine consciousness, which is currently theoretical and it happens to be more superior to humans, which has better understanding of all the things which it is supposed to learn. So currently we are here. We are at the level of narrow AI, where it is able to solve specific tasks and it can execute or just exceed the human ability for that specific task. We are still long shot from general intelligence, which is able to solve any human task uh, better than a human. As I mentioned earlier, so machine consciousness or super AI is still a theoretical norm where it will be able to solve tasks better than us. On a broad spectrum, artificial intelligence is a general umbrella term which encompasses machine learning, deep learning, and artificial neural networks. We'll be talking mainly about artificial neural network, as the artificial neural network is the one which is used for day-to-day practice. So artificial neural network is the lowest subunit of artificial intelligence, which is comprised of machine learning. So artificial neural network generally are of two types. One is simple neural networks and convoluted neural networks. First, we will discuss about how an AI or a computer understands what we see. So here we see three numbers. So obviously we know that it is three. So irrespective of how it is written, our mind is trained to understand the squiggly letters with three pointy arms and two concavity is three because we have been trained to understand what that particular figure is. What machine sees is nothing but multiple pixels of various color densities. Usually it is bichromatic color density. So if it is white, it is completely on. If it is black, it is completely off. And if it is gray, it is somewhere between on and off. So we clearly understand that the letter is 3, not 8. Why? Because since our childhood, we have been trained to understand the figures as a particular thing. Say we write A in a particular way, C, E, D in a particular way. The reason is we have been trained to do so. So what computer sees, as I mentioned earlier, so here we take a 28 into 28 pixel image. So where individual pixel is called as a voxel. So here we can see a black has a gradient of 0 and one has a grade. One determines that the voxel is completely on, that is, it determines a white color. A gray color is somewhere between 0 and 1, and it tends to give a numerical value between 0 and 1 for a particular image or particular image where the individual pixel lights up. So whenever a image is shown to a computer, it lights up relevant pixels and it will be able to understand that the relevant pixel which it lights up corresponds to an individual digit. Now, how this works? 9 has a 0 and a small line, that it is has a small circle and a small vertical line. So if the neurons or if the individual pixel lights up in a circular manner with a small vertical line, then the computer tends to understand that it is 9. Similarly, 8, it has two circular intensity which lights up and it is able to understand that is 8. Similarly, 4 with multiple patterns of vertical and horizontal lines. So we need to understand that the convoluted neural network is very good for image recognition, and simple neural networks are very good for data utilization. So let us come to the components of artificial neural network. Multi-layer perceptron is most common artificial neural network which is used for data predictions and data analysis. So any artificial neural network generally comprises of 3 layers. One is an input layer, 2 is a hidden layer, and third one is an output layer. We'll go more in deep about the individual layers, how it works, along with an example. So this is the surgical image. We know it is a neck dissection, post neck dissection. We are seeing common facial vein, a retromandibular vein, along with anterior division of retromandibular vein, joining into the internal jugular vein. So how we know that all the structures are the individual structures, what we already know, is because we have been trained. We have been trained enough to understand these are the particular structures what we are dealing with. So how do we train a computer to understand what the structure is? So we need to first teach what normal is. Then we need to teach the constant landmarks. We need to teach consistent colors and consistent structures. Then we have to teach the normal variants. And next we need to teach it how to identify abnormal and then to categorize the abnormals. So bottom line is we need to use high quality images. We can also use real-time information. This can lead to reduction in complication, higher accuracy, and lowering the collateral damage of surgery. So what are the key components of artificial intelligence in surgical planning and execution? So there are various preoperative images like CT, MRI, and PET scan, which can help in pre-surgical diagnosis, risk assessment, and strategy development. So next would be digital patient modeling, like it can use a 3D virtual model to determine and simulate procedures to identify the various challenges before surgery. Surgical planning and simulation can be done using predictive analytics and also can be used as a tool for preoperative rehearsal prior to a complex surgical procedure. We can also use intraoperative medical imaging like fluoroscopy, ultrasound, and augmented reality to enhance the precision and live updates of surgical tissue and tissue conditions along with vital structures. It can also be used for education, like global collaboration via surgeons using various networks. And it can also support real time training and skill enhancements. It can also be used for high intensity focused ultrasounds, which can target a tissue non invasively, and it can enhance precise biological targeting, minimizing the collateral damage. So, robotics and automation can be used to assess minimally invasive procedures. It may improve the dexterity, stability, and accuracy beyond human limitations. There are latest surgical devices like smart instruments and wearables, which can be used to automate a particular task. Augmented reality can provide digital information on real time surgical views and also help in tracking and navigation. So basically, it can be broadly divided as an AI system should be able to sense, extract, and understand the data. After that, it should be able to assist us, both offline as well as online. Using these things, the applications are limitless. So we need to understand how we just discussed about what broadly the AI means. Now we'll go into individual examples of use of artificial intelligence in clinical practice. I will use some of the works which I have done. First, we'll go ahead with the use of predictive modeling in surgical practice, where we have used a simple neural network to determine a particular outcome. So let us start with the clinical data. So this is the paper which we published where we used artificial neural network to predict the post-operative hypocalcemia following total thyroidectomy. How did we do this? So the main objective of the study was to identify post-operative hypocalcemia and severity of hypocalcemia following total thyroidectomy. And the secondary objective was to determine the weightage using the factors predicting the hypocalcemia with artificial neural network. So it was a single center retrospective study where data from 3 years was taken, where treatment naive thyroid patients who have undergone total thyroidectomy for both benign and malignant nodules. We had excluded patients who required revision thyroid surgery. We used IBM SPSS version 26 for developing the multi-layer perceptron, and we used Stata 17 for data analytics and MS Excel for data synthesis. We had utilized various factors like age, gender, histopathology, tracheoesophageal groove involvement, whether the disease was locally advanced, whether there was a retrosternal extension, whether we had done a central compartment clearance, recurrent laryngeal nerve sacrifice, was it done intraoperatively, had we done sternotomy or not, and postoperative parathormone levels to determine whether patient had postoperative hypocalcemia. So we had used multi-layer perceptron as we discussed earlier. It has 3 layers. It has input layer, hidden, and an output layer. So I will briefly talk about how this artificial neural network works. So input layer is the layer where we are using independent variables, like that is clinical variables such as postoperative parathormone level, sternotomy, whether RLN sacrifice was done or not, retrosternal extension. So the factors which were used to determine hypocalcemia are fed into the input layer. So each input layer is assigned an initial weightage. So this initial weightage are then passed on to hidden layer. So The hidden layer is the layer which performs the processing and activation. Each input is processed through multiple neurons in the hidden layer. A mathematical transformation is done using the activation function. The hidden layer has the ability to detect patterns and linear as well as nonlinear relationships within the data. This processed value is then passed on to the output layer. The output layer is usually the predictive layer. It is the dependent variable. Here, our dependent variable, what we had taken was whether the patient had hypocalcemia or not. And the second dependent variable was to determine the severity of hypocalcemia. So the output layer produces a prediction of hypocalcemia and the severity of hypocalcemia. So the output actually is used to determine a clinical outcome. If output is incorrect, then the model enters what is called as a backward propagation. Backward propagation, also known as error correction. So here, the error or difference between the predicted and the actual values are calculated. The model determines which input feature contributed to the most error, and the weightage is adjusted to improve the overall accuracy. Next, the weights are updated and the model actively learns from the mistake which it is caused. So the model updates the weights to reduce the future errors. The forward propagation and backward propagations are repeated multiple times. These are called as generations or epochs. So for any medical literature, we need to run a model for at least 10 generations with different training and testing sets. This will reduce the term called as bootstrapping. So the probability of bootstrapping will be reduced if we run the model for at least 10 generation using various training and testing data set. Finally, the artificial neural network is trained to accurately determine the outcome, that is the possibility of hypocalcemia in patients who have undergone post-operative uh, thyroidectomy. So here, the input layer consisted of 9 neurons, which were individual independent factors, which we discussed earlier. And the individual variables were rescaled for the model to understand using standardized method. So we were discussing about the weights. So this is the function formula where the outcome variable is determined by the product of weights with an individual feature and sum of all weights along with products along with the bias, which is to improve the model accuracy. So the hidden layer in our model consisted of one layer which had around 7 to 9 neurons which were automated to optimize. So the activation functions can be various. Here, we had used hyperbolic tangent function. So the output layer here, as we discussed earlier, had hypocalcemia, which was dependent variable, and severity of hypocalcemia. So we had two units in the output layer, which were automated to optimize. The activation function here we used was identity. And to determine the error function, we use sum squared as the function here. So as we discussed earlier, so the input layer, hidden layer, and output layers are very important for artificial neural network. So whenever we do an artificial neural network, we should always compare it with the conventional statistics. So the conventional statistics, appropriate statistical test has to be applied to determine significance for individual factors. Here we had used chi-square test to determine the significance of the factors which led to hypocalcemia. And we had run the model for 10 generations using multi-layer perceptron, and we had validated the model using the mean square error, root mean square error, and also determined the accuracy using ROC curve. So we had included around 196 patients, so wherein the overall rate of hypocalcemia was 12.8%, with mild being the most common, which was 15, followed by moderate and severe. So here, based on the conventional statistics, we found that locally advanced thyroid cancer, central compartment clearance, recurrent laryngeal nerve sacrifice, retrosternal extension, sternotomy, and tracheoesophageal groove involvement showed it to be significant. So when we ran the model for 10 generations, this was the mean square error. So every single time the model tends to give individual weightage for individual factors, we found that the percentage incorrect correct predictions was only 6.53% in validation set, and it was 7.2% in training set. So number of correct predictions was 96%, and number of correct predictions of severe hypocalcemia was 93.5%, and the model at root mean square value was 0.29. If the value is less than 0.3, then the model is good enough. So the weightage were calculated, and it had given maximum weightage to the post-operative parathormone level. So the 100% is just a value here. It is the arbitrary weightage which is given. It is not to be considered as the most significant factor. So the weightage given to the post-operative PTH was 100%. That is, it was 0.1. And the sternotomy received the second most, which was 28%. So the root mean square error was around 0.2, 0.28, which said that the model was fairly accurate. And this was the accuracy which suggested that hypocalcemia was determined in 98.2% patients accurately. And the severity of hypocalcemia was determined with almost around 95% accuracy. Similarly, I had done one more study along with cardiac anesthetists at Jaideva Institute of Cardiology, where we determined the factors which led to reintubation in patients who are undergoing pediatric cardiac surgery. So the objectives were quite similar, where we tried to identify the factors which led to reintubation in patients who were undergoing pediatric cardiac surgery. And secondary objective was to determine the weightage for the factors predicting the reintubations. So this was the model which had input, hidden, and output layer. So here we had around 294 patients. We had used various factors to determine the reintubation. So here the model was fairly accurate, where it was able. So this was the ROC curve for the duration of ventilation and ROC curve for the complexity of the surgeries which was done. So here the model, what we used was again multi-layer perceptron. We achieved an accuracy of 95.12% and a testing accuracy of 92.1% with a sensitivity of around 93% with a root mean square value of 0.24. So here the importance was most commonly given to WBC count, followed by the complexity of surgery, and later other factors were also given importance. So here we can see a graph of various factor weightage over 10 generations. So we can see consistently that WBC count has been given highest weightage compared to the other factors. So we had done a comparison between a conventional statistics and artificial neural network. So here we found that WBC count, which was not reported by conventional statistics, was reported by the neural network, where it had given highest importance. So the complexity of surgery was found to be significant in both. BMI was found to be significant in both. And here we can also see that Ratchet score, that is the complexity of surgery, various types of surgery was shown to have that more complex surgery has higher chances of reintubation. So we can see here that the model had less than zero point 0.3 root mean square value over the 10 generations, suggesting that the model is fairly accurate. So this is the accuracy of the model, which was run for 10 generation. We can see that the accuracy was not uniform over 10 generation, and the generation 7 and 8 had slightly lower accuracy, but generation 9 and generation 10 picked up the accuracy. It nearly came back to normal. So we were able to identify both linear as well as non-linear patterns using multi-layer perceptrons, which was not possible to see in conventional statistics. So this was about how we can use artificial neural network to determine the data or for predictive modeling. So now how to utilize image uh, data to understand or to predict what the structure is. So here we'll be using an open source software called as RoboFlow, where we'll be using the image segmentation software or image classifier software, where we are using the CT scan of a patient at the level of hyoid. This is the axial section. We are going to train the model by teaching the structures individually and annotating it to teach the neural network what it is and trying to predict what the structure is by using a complex convoluted neural network. So here, once we start RoboFlow, we'll be given the project name annotation group. And the RoboFlow is an open source software. It is licensed by Creative Commons 4.0. So we are using object detection, classifier system, segmentation, and key detection and multimodal. So here we have used a classification system. So once we start, so we'll be shown to a portal where we have to upload the individual patient data. Once the individual patient data are uploaded, it will go into the unassigned box. So the here, just to show, I have used the example of the the axial CT scans at the level of hyoid, where we have annotated the model. So we have used around 29 images. We have annotated this individually. So it was done by me and my colleague at Shankara Hospital. So we had uploaded individually and we had annotated individual structures on CT scan, such as carotid, hyoid, internal jugular vein, mandible, preepiglottic space, sternocleidomastoid muscle, uh, and tongue muscle individually. So this is how we had annotated individual structures. And when we annotate, we color code what the particular structure is. So we had used around 29 images to annotate the individual structures, and we had around 430 annotations. So the average pixel was around 0.26, and the image ratio was 512. Here we were just trying to test out whether the convoluted neural network, that is the COCO model, was good enough to identify the structures on CT scan. So here we can see carotid was annotated 58 times and rest of the structures at individual levels in training and testing set and validation set. So here you can see the legend of annotation in a CT scan. That is, it mainly came around the center and less came around the periphery. So we had used RoboFlow 3.0 image or instance segmentation model. The checkpoint used was COCO and segment. So these are the image analytic graphs. So the training and testing set, it is the mean accuracy percentage. So the mean accuracy percentage is around 78%. So the model was around 78% accurate overall. So based on the classifier here, we can see the average precision. So the average precision of a structure which was constant, a bony structure, was very high. So the hyoid bone achieved 100%. Pre-epiglottic space in our patients was quite common. Submandibular gland was in the normal position. So these were the ones which achieved higher accuracy and higher precision. So also we need to understand that we are dealing only with around 29 images here. So if we increase the number of images, the quality of image, then the accuracy tends to increase. So these are the further training graphs which are determined using the Coco flow model, which will be able to tell us Bok loss, segment loss, class loss, and the average precision, both recall precision in validation and training set. This will be able to give us the model metrics. So after this, when we upload them, so this model has been trained to understand the structures based on our annotation training and testing set. Now we need to validate whether what model is telling is correct or wrong. So we need to upload a new scan, a nascent scan. We need to ask the model to determine the structures, and we need to individually calculate the sensitivity of determining hyoid, sensitivity of determining supraglottic airway, sternocleidomastoid, SCM, and carotid artery. So here what we found, so we are still going ahead with this uh, particular project. So what we came to a conclusion that the model is fairly accurate, but the confidence what with which model tends to predict is lesser because the model was trained only with 29 patient data set. So after validating the model, this Coco flow, Coco segment model can be run on any device using API key. API key is nothing but application program interface. So this API key can be downloaded and this model can be deployed using a mobile phone. So you can literally download a software and use your iPhone to just show on a particular CT scan, and then it'll be able to highlight which structure is on a real-time basis, similar to augmented reality, what you have been seeing. So you just have to download RoboFlow CocoaPod, put in the API key, and you're good to go. So now coming to current research on artificial intelligence in surgery. So there have been various developments. So like it has been used to determine the procedure duration prediction using various models. There is gesture recognition, intraoperative cancer detection, intraoperative video analysis. So recently, when I had attended North American Skull Base Society, so they have created a model where the entire 8 hour, 10 hour surgical video is just summarized into a 2 minute video with important steps. So this has been done by a team in MD Anderson. So they are still working on it. They told that the accuracy of this model is fairly high, so which comes almost about around 95%. So it is also able to understand workflow recognition, endoscopic guided systems, and knot tying can also be done using artificial intelligence. We can also do automatic registration and tracking of bone in orthopedic surgeries. So just to highlight on various surgical use of artificial intelligence. So this is one excellent video where laparoscopic structures were annotated and trained to identify. So this is a gallbladder surgery where laparoscopic image is fed and it real-time identification of hepatic artery and gallbladder is done here, which will aid the surgeon to identify relative ease. Similarly, again, this is one more video where it is able to identify the Carlot's triangle, cystic artery, and it is able to identify the CBD. Similarly, this is laparoscopic surgery where it is able to identify the triangle of doom. So we have also been in works with the endoscopic team where we are determining the factors or determining various components in endoscopic surgery to identify like turbinate septum, inferior turbinate real time. We have also been using artificial intelligence to determine the focus of cancer in a patient who has ill-defined leukoplakia using near-infrared autofluorescence. So we are still in works with IRLIC team. So we are actively pursuing this project. So similarly, we have been using artificial intelligence to train, to identify the places where we can perforate the radial freeform flap for zygomatic implant insertion. Also to determine the bulk of muscle which is used for reconstructing the infratemporal fossa defect when we are using chimeric anterolateral thigh flaps. So the applications can be very limitless. So it can support surgical decision making, improve precision, improve workflow, increase surgical safety, reduce manpower, and also you never know, it can have autonomous function later. So we have been speaking only about advantages of artificial intelligence. We need to understand the limitations of artificial intelligence, especially in surgery and mostly in head and neck oncology. So recently we came out with a consensus paper on limitations of artificial intelligence in head and neck oncology. This is still in print, so I will share the full text once it is out. So the limitations mainly being the clinician mistrust and lack of understanding. So the hidden layer, what I was discussing, so it is called as a black box uh, because how it comes up with weightage and how it learns by forward and backward propagation is still not known. So there is lack of transparency in decision making. So it reduces the rate of adoption of this AI models. So there is a lot of algorithm bias and data limitation. So the AI model trained on non-representative data sets can lead to a lot of disparities, and variation in imaging protocol can lead to generalizability of artificial intelligence. So there can also be over-reliance of artificial intelligence and erosion of surgeons' expertise. So a dependence on AI may diminish clinical judgment, and artificial intelligence lacks the contextual ability of a human expert. So there are a lot of challenges for AI adaptation in routine practice. That is, the data quality is most important. That is, high quality annotated data sets are very scarce. And then financial accessibility barrier is extremely high. That is, the high cost limits the AI adoption in resource poor settings. Ethical and legal concerns have to be addressed, that is, AI accountability, privacy laws, and regulatory approval processes complicate its regular implementation. Evolving cancer biology, that is, AI struggles with complex and dynamic oncologic data. So what are the proposed solutions for this? So we need to create transparent AI models, which have recently come across. It's called as an explainable AI, which can improve the trust. So mainly what it does is it will be able to explain every single step what it uses, and it will be able to tell it with certainty how it has given individual weightages. We also need to have diverse and validated data sets. So I was discussing about 29 patient data. So although it was done to show how well we have been able to use convoluted neural network to determine individual component on a CT scan, we need to have good quality data, higher number of data to address the algorithm bias. We also need to educate clinicians, and we need to let them train with AI. So it will be able to improve the adoption of the artificial intelligence in clinical use, and also most importantly, a responsible use. We need to have regulatory framework. Although we do not have regulatory framework in any part of the world, if we are using AI in determining a surgical outcome or surgical wearable, then it is considered as a surgical device. And in America, so FDA is regulating that. Similarly, there are regulatory bodies in Europe, which regulates that. In India, currently, we do not have any body which is able to regulate the artificial intelligence. We also need to have collaborative research, multi-center data sharing to enhance the AI effectiveness. Um, so, as Elon Musk said, AI will be for the best or the worst thing ever for the humanity. Thank you very much for your patient hearing. I am Dr. Karthik, consultant head, Sri Shankara Cancer Hospital. You can reach out to me if you have any queries pertaining to artificial intelligence, using it for either data analysis or for image analysis. You can mail me on the provided email ID. I'll be able to support you with any kind of understanding that needs to be done. Thank you very much. Hope you enjoyed the session.